With that in mind, I was given a slightly different topic, and as Everett just said, immune checkpoint inhibitors in first-line recurrent metastatic head and neck cancer and beyond, which of course invokes Toy Story. And if, for those of you who are familiar with the characters, that was this character's saying to infinity and beyond. And you know, perhaps I'm just on the edge of the bubble here, but maybe we are at a point in many cancers, including head and neck cancer, that we are beginning to push the limits and think about treating patients, and I dare say even curing patients that we never dreamed of before. So I actually thought this was quite appropriate that we think about Buzz Lightyear in the context of immunotherapy. With that in mind, I'll go over a number of planned trials is probably the best way to characterize this talk and give you a sense of where the field is moving in recurrent metastatic disease, especially the trials in first line that are attempting to integrate these agents or maybe even compare these agents to standard therapies. It started, or not the whole thing, but I'll start with a clinical trials planning meeting that was sponsored by the National Cancer Institute that occurred now almost, actually a little bit more than a year ago. Bob Ferris, Julie Bauman, and I co-chaired this meeting, and thanks actually really to Bob and Julie, who did almost all of the work for setting it up and making it happen. The meeting was constructed to really look at immunotherapy in several settings of head and neck cancer. You heard Everett talk about the previously untreated locally advanced disease, and what I'll focus on is working group 3, and that was the recurrent metastatic disease. Here you see the 3 working groups, actually the 4 working groups. The 4th working group focused on biomarkers, and again, more than happy to talk about all the outcomes, but I'm going to focus on recurrent metastatic disease for the talk. And Scott Stroman and I chaired that working group. And basically, here you see the membership. Very happy to have participation from several people and excellent input from the entire group. And we came up with 2 studies or 2 study designs that we then took to the NCI, not impaired, implored the NCI to take forward into the cooperative groups. The first tested a hypothesis that radiation therapy could augment immune checkpoint inhibitors in the form of stereotactic body radiation, that hypofractionated doses of radiation in the form of SBRT could enhance the immunologic effect of an anti-PD-1 therapy in head and neck cancer. The original design that came out of the meeting used pembrolizumab in this setting, and here you see arm 2 as pembrolizumab alone, and arm 1, really the hypothesis testing arm, combining pembro with SBRT. I can tell you now that the immune checkpoint inhibitor has changed. I'm not actually allowed to tell you what it's changed to, but the trial is going forward with a similar, very similar compound, but not the compound that you see in front of you. The other study that came out of this was a more exploratory randomized phase 2 effort that now utilizes cetuximab as the backbone in second-line recurrent metastatic disease. And we talked about the use of cetuximab in this setting, and you've heard a lot about that. But capitalizes on cetuximab's ability to induce an immune response. And again, there are very good data surrounding that now, and adding different checkpoint inhibitors. Or the first arm adds quite simply an anti-CD37 or 4-1BB, a T-cell stimulatory factor. The second adds an anti-PD-1 monoclonal antibody, and the third arm combines all 3 drugs. I'm happy to say that this trial is indeed going forward in ECOG with the agents nearly completely identified. Well, that came out of an effort about a year ago and continuing to move forward. What about the efforts that are actually going on, the trials that are accruing? Here, I won't show you the Checkmate 141 because Bob showed it and Everett just showed it. That's the BMS study that in the second line that compared nivolumab to standard of care. But there are, of course, other studies, and here is trial design Keynote 048. This is now a first-line trial looking at patients after stratifying for tumor PD-L1 status, HPV status, and ECOG. Patients who now had never been treated for recurrent and metastatic disease, who were randomized to the standard of care being, in this case, the extreme regimen. The extreme regimen, for those of you who aren't familiar with it, combines platinum 5-FU and cetuximab and is the only approved regimen in the United States and Europe for the treatment of first-line recurrent metastatic head and neck cancer. In one arm of this study, the cetuximab is substituted for pembrolizumab, so now platinum 5-FU and pembro. And then the third arm, quite provocatively, that you see at the top, is pembrolizumab alone, with the hypothesis that a single agent in the form of immune checkpoint inhibitor may actually demonstrate superior efficacy to the extreme regimen, a triplet regimen of systemic agents. And quite honestly, from the phase 2 study that's been presented, this may not be as crazy as some of us think it is. Of course, there are other agents, other immune checkpoint inhibitors that are active in head and neck cancer. You heard about durvalumab. Here are the data that were presented in Europe now almost a couple of years ago, looking at an expansion cohort of head and neck cancer patients of about 45 patients, demonstrating indeed activity of a PD-L1 antibody, durvalumab, in patients with recurrent metastatic head and neck cancer. We can debate whether HPV positive or HPV negative patients seem to benefit more, although what was clear from this data set is that PD-L1 positive patients appear to be the ones that were most responsive to an PD-L1 antibody. Interestingly enough, as Bob showed you, for PD-L1 negative patients, at least in the setting of squamous cell carcinoma of the lung, a combination of durvalumab and tremelimumab appear to be quite effective with an over 30% response rate, again, PD-L1 negative patients. So with that in mind, AstraZeneca has now undertaken also a phase 3 first-line recurrent metastatic trial. And here you see the stratification factors of PD-L1 status, tumor location, and smoking history, with a randomization to standard of care, which is extreme, the same extreme regimen that I just told you about, and the two experimental arms now being this doublet of durvalumab and tremelimumab versus durvalumab alone. Again, with the idea that in immunotherapy may in fact prove to be superior to standard cytotoxic chemotherapy with cetuximab. This trial just started accrual and will hopefully go very well. And I'll leave you with one more of the ongoing studies, and this I bring up for a couple of reasons. It's the so-called Javelin trial. So a drug that you may not be as familiar with. So avelumab was perhaps a little bit late to the party. Arguably fashionably late, maybe, but a little bit late to the party. And this is the so-called Javelin medley trial, and it's interesting for a couple of points. First of all, germane to the talk, there's a cohort of squamous cell carcinoma of the head and neck patients that you see outlined in yellow. But what's really nice about this study is that it capitalizes on the pipeline that Pfizer and somewhat Merck Serono have, and begins to automatically combine this PD-L1 antibody with some of the other agents in the pipeline. And they will do this in the context of course, a clinical trial and systematically. The first attempt is with a 4-1BB inhibitor, but the second, third, and fourth attempts are already planned out with agents such as OX40, CCR2, and other drugs in their pipeline. So in a iterative manner, this trial will test immune checkpoint inhibitors with other agents that also affect the immune system and the tumor microenvironment. So in my opinion, that's really one of the areas that the field needs to go. I know I'm supposed to talk about checkpoint inhibitors, but I can't resist to mention that they are not the only agents that have been tried in head and neck cancer. Here's a study that was completed using a toll-like receptor 8 agonist called metolimod. We've known a lot about the toll-like receptor system, of course, because it's an important part of the innate immune system. And this takes advantage of the fact that the drug actually synergizes with chemotherapy, chemotherapies that are relevant to squamous cell carcinoma of the head and neck. The idea that we can activate myeloid-derived dendritic cells and thereby activate not only NK cells, but indirectly, eventually, CD8 positive T cells. Some nice data from Nora Disis's group showing that, in fact, in the setting of an IgG1 antibody, this agent can lead to dramatically increased cell lysis. So cetuximab, rituximab, trastuzumab, all, of course, IgG1 antibodies that can activate ADCC. And again, from the Seattle group demonstrating that at least from a tolerability and feasibility point of view, the drug can be combined with cetuximab. And intriguingly, a couple of patients on this study that appeared to have dramatic benefit from this combination. It's a phase 1 study, and all the caveats kept in mind in terms of the efficacy. But with all those data coming together, Bob and I, along with some other collaborators in this room, started to think about a phase 3 trial comparing now, again, the extreme regimen of platinum 5-FU and cetuximab in a double-blinded manner, adding metolimod, both in terms of initial therapy and then as maintenance therapy with cetuximab. This trial has completed accrual. It actually accrued 190 patients, not the 175 that you see here, and hopefully we'll see data in early part of 2016. Lastly, I'll leave you with some data that we've developed at the University of California, San Diego, also using toll-like receptors, but slightly different TLRs, that is agonist to TLR9, SD101, and an agonist to TLR7, 1V270. Actually 1V270, sorry. The 270 is the numerical attempt at developing a toll-like receptor 7 agonist. So lots of trials finally got one right. These are interesting drugs. I'll draw your attention to a couple of points on these graphs. First of all, the top is an HPV positive cell line. The bottom is an HPV negative cell line. These are both, of course, in immunocompetent mice. But if you'll just look closely for a minute, what we see with these agents is that upon intratumoral injection, and of course shrinkage, dramatic shrinkage, and in fact even cure of these mice with both toll-like receptor agonists in both HPV positive and negative models. But what we also see is dramatic efficacy in the uninjected site. So what we do in this model is that we inject tumors in both flanks. And remarkably enough, we see very nice responses in the other flank that was not injected with the toll-like receptor agonist with synergistic activity with an anti-PD-1 antibody, suggesting that, in fact, these agents can induce an immune response beyond the tumor that's actually injected. And I'm happy to say that as part of a spore application, we're taking this drug forward with pembrolizumab in a phase 2 study in patients with recurrent metastatic head and neck cancer. So with that in mind, again, my time is up. I've gone over time. I apologize, but I'll leave you with a couple of thoughts. There are, of course, many ongoing studies incorporating immunotherapy agents, and I used ongoing twice there, and there's just simply not enough time to mention them all, but there's clearly an incredible amount of excitement in the field. The current phase 3 trials are likely to garner approval for what will be a PD-1 antibody in 2016. If I had to guess, nivolumab will be approved, and on the heels of that, likely pembrolizumab. That the current focus now should be on rationally combining immunotherapies. I think that's where we're going to get the most bang for our buck. and that the needs are now to begin thinking beyond PD-1 and PD-L1 and other ways to modulate the immune system. We clearly need to develop biomarkers, especially predictive ones, and there's been a lot of talk about that. And we also, as Everett again elegantly pointed out, to really make an impact in this disease, we need to think beyond recurrent and metastatic disease. And of course, we're doing that. So again, thank you for the invitation and thank you for your attention. Now I will stay up here. Okay.
I think Janice said we should have head and neck